Hello, thank you all for joining us this afternoon. We are very excited about today's webinar. Today we'll be talking about the use of telemedicine during the pandemic. And we have two leaders in their field, and so I'm very excited to have them with us today. And I will be moderating the discussion. For those of you who don't know me or aren't familiar with my work, my name is Keonta Moore, and I'm a fellow here at the Baker Institute in Child Health Policy. I don't want to delay any longer, but I do have a few housekeeping rules for our webinar today. So we will have a moderated discussion, a question and answer at the end of our speakers, but please, while the speakers are talking, if you have questions, please put them in the Q&A function at the bottom of your screen. Do not enter any questions into the chat button because those questions will not be asked. Only the questions in the question and answer button will be asked to our panelists. And so we will have first Dr. Heidi Schwarzwald. She currently serves as the Chief Medical Officer for Aetna Better Health of Texas, which is Aetna's Medicaid and CHIP plan. She's a pediatrician, having completed her training at Cincinnati College of Medicine and Baylor College of Medicine. She has worked as a clinician and medical director focused on caring for underserved populations in Texas for over 20 years. Her past experience includes designing and opening fully capitated clinics for Medicaid patients, as well as providing care internationally for HIV-infected patients. Without further ado, I'm going to turn it over to Dr. Schwarzwald. Thank you.
Thank you. Just give me one moment to get that shared. It is my pleasure to talk to you today. Thank you so much for having me. And I'm going to really focus on the payer's point of view when we're talking about telehealth and telemedicine, talking about what is the same and what has really changed since March, which doesn't feel that long ago and yet at the same time feels very long ago. You know, telemedicine is something that we have been talking about for a very, very long time. I think you can go back 10 years, even more, and see discussions about how it's going to disrupt medicine, how it's going to provide new opportunities for access to care. And yet we haven't really seen it come to fruition, I think, until really just recently these last few months. So I'm excited to talk about this and see sort of where we're going to go from here. Before I start, I just want to lay some definitions so that we are all talking about the same thing. You will often hear many, many different types of words used: e-health, telemedicine, telehealth, telemonitoring. So if you look at sort of the Texas regulations, they really define telemedicine and telehealth. And they really define telemedicine as that which is provided by a physician or a physician delegate. So those are your physicians, your nurse practitioners, your physician assistants are really those that they are focused on for who's providing that care. Certainly pre-COVID, it was meant to have diagnosis, assessment, and treatment of part of what you're doing, and was meant to be video capable, whether that was a live interactive video or whether that was what's sometimes referred to as asynchronous or stow and go, where videos are uploaded, interpreted, and then information sent back. Telehealth is really talking about anything provided by licensed or certified professionals. So that's where you start to talk about your therapist, whether it's your behavioral health therapist, physical, occupational speech therapy, other types of licensed professionals outside of sort of your more medical, physically focused physicians and nurse practitioners. It again was meant to be video capable and interactive. Now, CMS actually uses telehealth to cover both of these universes. And so for the rest of the talk, I'm going to refer to telehealth, really using the CMS definition, so meaning both telemedicine and telehealth in the Texas definition. Telemonitoring is the last thing you'll hear often, and that really has more to do with putting equipment in someone's home so that you are seeing you're able to sort of monitor them remotely by a health practitioner. But we're really going to talk about telehealth today. So this really gets a sort of a very short view of the history of telemedicine. But I think it's really striking that it was really in 1993 that the American Telehealth Association was founded. And this is an organization that really brings together health professionals from lots of different disciplines talking about sort of best practices in telehealth. And that, in medical terms, that's a while ago. And yet, when you looked at 2019, still only 2.4% of patients were saying they had ever used telehealth, and only 18% of providers were saying that they were offering it. Fast forward to really the last couple of months, and some of the early data said over 50% of providers are offering telehealth. I'd venture to guess that number has increased since then. And then individual practitioners just saw an absolute increase in their numbers. So there was an article published looking at Texas Children's Hospital here in Houston, going from maybe 1 to 2 visits a day to 2,000 visits a day very, very quickly. And Duke Health, the same thing. They were reporting 100 visits a month and then suddenly reporting far more. So I think it's a great opportunity to really do some very rapid looks at what works and what doesn't work. And actually, Congress is looking at a new bill, really charging the government with sort of looking at what are the successes that have come out of this rapid experiment, sort of live experiment, and how much access is improved and whether that improved access is equitable across all different groups. So I don't know that that is passed yet, but certainly looking forward to having that support and really looking at what we're doing and keeping the best practices and maybe changing or altering those that don't provide the outcomes that we all want. I do want to spend a couple of slides today talking about the regulation, and I would just say that it is definitely confusing. So there are some regulations that come from CMS, very much overseeing Medicare and some of the Medicaid. Within each individual state, there will be other regulations, and those will sometimes apply to commercial, Medicare, and Medicaid. Certainly Medicaid often defaults to sort of those state level regulations. And then you may see in the commercial world, even to this sort of the individual insurance company, some different rules and regulations. And so I would just say, if you are a provider who's giving telehealth services, this is admittedly a confusing space. And I would say, lots of careful research and watching sort of who is your payer is really going to dictate some of the things. And hopefully one of the things that will come out of what we've seen in these last couple of months with this pandemic is maybe some universal programs that make that a little bit less confusing. So what really are some of those regulations that have changed in the last couple of months? And many of these changes have really come from CMS and others have aligned to them. One of, I think, the really important ones is around what constitutes a pre-existing relationship or whether a pre-existing relationship is even required. Texas had liberalized some of this language several years ago, but for CMS and for Medicare patients, that's really new with the COVID, saying that you do not have to have had an in-person visit prior to establishing a care relationship via telehealth. And they've really redefined sort of how you establish that care relationship. It still has many of the elements that would be in a visit anyway, reviewing medications, taking a history, etc. But you can now do that virtually, and that really opens up access for a lot of providers and a lot of patients. Another change is services being delivered into the home. So again, that had already been allowed in Texas for certain groups, but not always for Medicare. And now the Medicare patient can actually be in their home rather than having to be in a clinic to receive those telehealth services. There were some changes in liberalizations and some of the rules for the federally qualified health centers and rural health centers, but I'm going to defer to our next speaker as that's really part of what she's going to be speaking about. One of the biggest changes we've really seen is around the type of software. So pre-COVID, you had to use software that was HIPAA compliant. What that meant realistically was that most providers who were doing telehealth had a portal. A member or a patient had to download that to their phone or to their computer, create a login, sign in, and then utilize that so that you were so that privacy was made fit the HIPAA compliant privacy. Very early on in the COVID pandemic, that's one of the things that was released. So you cannot use any type of video exchange with a patient if it is something that other people could join. So the legislation actually says you cannot use Facebook Live. But what you can use is you can use Skype, you can use FaceTime if you're both on an iPhone, you could use WhatsApp, Google Duo. So there are a lot of other opportunities. And I also think this has eased some of the access. These are programs that people are used to using. And so that when they're using them now to talk to their physician, the same way they're using them to do other functions in their lives, that it is an easier adoption. And in the past, it generally was very clear that you had to have both an audio and a video component to your services. But you'll see that many of the regulations have now said that telephone-only consultations can be accepted as telehealth consultations. And that is also a huge shift and really is opening up access to many people. I will say, as a provider who has done telehealth visits, I like the video component. I think it certainly helps you get a better sense of what is happening with your patient. But I certainly understand that in times, sometimes that is not applicable, and you would far prefer that there is some access to care being given than no access to care at all. Some of the rules, though, have stayed the same, and I think it's very good that some of these have stayed the same. So your scope of practice should remain the same. You should not be practicing any type of medicine or any type of therapy via telehealth that you wouldn't normally practice in person. Common sense, but worth sort of stating. And standard of care needs to be maintained. So those things that are required in your standard of care for that particular type of office visit or consultation really need to be maintained. And that makes sense too. We don't want to see a degradation in the quality of care that people are getting because we've slipped to a new modality. Consent still needs to be obtained and documented. So if you're using one of the softwares that were designed specifically for telehealth, then oftentimes there is a place where the patient will sort of put in their consent before they begin their visit. But if you're using Skype or Zoom or any of these other modalities that weren't really designed for telehealth, then you're not necessarily going to have that. And then you have to make sure that you are collecting some kind of consent, whether it's verbal consent that's documented in your note, or whether they're through another patient portal mechanism, if you have something else set up for your patients already, that you are collecting that consent. And then all of the regular documentation remains required. So you should be having access to your electronic medical record. If it's still paper, there still needs to be some sort of paper record that's documenting that visit and what transpired in that visit. And usually best practice is to document the modality that was used. If you're doing behavioral health therapy, start-stop times, all of those things remain. Prior authorization has been interesting. So in general, and again, this is something that may change between Medicare, Medicaid, and some of the commercial plans, but in general, if something required prior authorization when it wasn't done via telehealth, it still requires prior authorization today. Certainly in this pandemic, there have been some loosening of some of the prior authorization requirements, but those have to really do with the pandemic and not necessarily with the fact that you're using a telehealth modality. On the flip side, most of the payers have also said, look, if you already got a prior auth for the service and your intent was to provide it in person and now you're providing it via telehealth, we're not asking you to get another prior authorization. That prior authorization remains in place. And so that's hopefully making it smoother for some folks. There is one provision that has remained in place. It is a little bit unique for Texas Medicaid, and that really has to do with communication with the PCP. So this was really put in place to preserve the medical home, right? A very important concept that patients have a medical home. So hopefully in this era, many of the medical homes are actually providing telehealth, and I believe that many, many of them are. But if you are not the medical home, a specialist, urgent care, providing other types of services, there's still an expectation that the same as you would if you saw that patient in your clinic and you would communicate back to their PCP, that you really should be doing that even if you're seeing them via telehealth. We want you communicating back to the PCP, and I do have the full language there. So that is something that is a little bit unique, but has certainly remained in place. So telehealth reimbursement. So prior to COVID, oftentimes reimbursement was a little bit less for a telehealth visit than for an in-person visit. And certainly both the national and the state regulations have said, nope, during the pandemic, you are going to be reimbursed at the same rate for a telehealth visit. And I think that's great. I think that's really important that providers are being reimbursed for that care. And this even does apply, like I said, to some of the telephone-only visits. So an office visit can be done via telephone only and be reimbursed at the same rate as an in-person. For Medicaid, they've also opened up well child checks or Texas Health Step visits, but those usually need a follow-up with at least a short in-person visit to make sure you're getting some of those physical exam portions and, of course, giving immunizations. And again, almost all co-pays have been waived. So most commercial plans have waived their co-pays. For CHIP in the state of Texas, certainly co-pays have been waived, and most Medicaid didn't have co-pays. So all of these, I think, are regulations that have really tried to ease the some of the barriers between providers and patients when you're trying to provide telehealth, but I think there are still some really important barriers that we need to continue to address as we move through the pandemic and hopefully beyond the pandemic, keeping some of our best practices. So there is certainly a problem with an absence of technology. So if you look at households with folks 65 years or older, almost a third of them don't have a computer at home. Most everybody does have a smartphone, and those can be utilized for telehealth, but sometimes a computer is an easier modality. And the same for Black and Hispanic children, 30% don't have a computer at home. Again, very often there may be a smartphone in the house, but that might be utilized for somebody else's work or for school or for something else, and can it be utilized by that child at the time that it's needed? Digital literacy is also a really important part of effective telehealth. So 52 million Americans said they didn't know how to use a computer or use a patient portal. And when they looked again at elderly patients and families, only 60% of them actually were able to effectively send an email. So what I think many of us take for granted, and that digital literacy, I think it's really important that we are addressing that. You know, older patients make up a large number of the patients that are seen in clinics. And if there is not digital literacy, we need to be helping them get over that barrier to getting access to care. And then it's just whether you have access to enough bandwidth to be able to do video and telephone interaction. So almost 28% of rural Texans don't have access to broadband, and up to 58% of low-income Texans say they do have broadband, but that means many others don't. And so again, we really need to make sure that we are working towards equitable access to the tools that you need to then have equitable access to the healthcare. And so that's really, again, I want to focus on where are some of those access issues. And when you don't have access these days to the internet and to broadband and feeling comfortable utilizing it, then you're really getting cut out. You're getting cut out of your physical health, you're getting cut out of behavioral health care, and then, of course, getting cut out of education. And as a pediatrician, I really have to think about education as part of our healthcare. Of course, the social determinants of health, this is only a tiny, tiny part of that, but this all plays into the global well-being of our pediatric patients. And I definitely have some concerns about what has happened in the tail end of our school year and what they're talking about for the beginning of the school year. So we've seen a massive rise, no big surprise, during this pandemic of anxiety, depression, and loneliness. So that means that concomitantly we need to have a rise in access to behavioral health services for our patients and our families and our communities. And making sure that everybody has access to online ways, and telehealth is an important part of that. I did see one study last week that actually showed that with the flip to telehealth, there's been an increase in availability of behavioral health in some of our rural communities. So that, I think, is a great step forward, and hopefully we'll see more of that as we move through the pandemic and post-pandemic. Talking about education, though, again, there were some early studies that over a third, 36% of children couldn't complete the homework that was assigned because they didn't have access to a computer or other modalities to participate. Anecdotally, we certainly heard from students and families in HISD and other large schools that students were really struggling to attend those classes. So if we're going to start this fall again with online school, we have to make sure everybody can access it. 28% of folks who were interviewed last month were asked about if they think they'll be able to continue having high-speed internet. And a lot of them were concerned that as job loss increases, that they won't be able to continue paying that bill and therefore will lose the access they have today. There was one really good study done really pre-pandemic looking at this idea of access. And they looked at two communities in Cleveland, Ohio. One, they put free Wi-Fi in the entire community. One was sort of steady state where people were paying for their Wi-Fi. And they saw a 50% increase in participation in any kind of health via the internet, even just using a patient portal. So I do think that we really need to be having conversations about how we're providing access in our communities to remove that digital divide. So some solutions, many of these come from a recent study that was published out of San Francisco in the New England Journal of Medicine. And I think some of them are common sense, but I think we need to start to discuss them as a community, as providers, as payers, to make sure that we are having equitable access. So the FCC, of course, needs to focus on this, and they are, and there's been lots of reports about how they are trying to increase access in rural areas and in urban areas. I think public-private partnerships to continue making hardware available to patients and to children. And I will say there are lots of good groups working on that here in Houston and in Texas. Lots of the large computer companies really do that. I will give one quick little shout out, and I will say that this is not sponsored by Aetna, but just a personal shout out. There is a group here in Houston called CompuDop, and they are doing on June 15th a drop-off between 10 and 5. You can drive by and drop off any old Macs or any PCs that you have, and then those get redistributed to school children in our community so they can participate. So I'll end my ad there, but if you want to know more about that, we're happy to help with that. And there needs to be training on use, which we've talked about already. There needs to be some hands-on training for folks who aren't comfortable before they're going to have a successful visit. We have to make sure there's adequate translation services. We have to make sure that we can speak to everyone who needs our services. And much has been looked at where you remove the requirement for accessing a patient portal, it's easier for folks to access. And then of course, finally, that telephone only. I do think that is something that we need to have a careful balance, making it available, but not seeing abuse in that within our system. So I think there are lots of other opportunities out there, but I think these are some of the quick solutions we can look to continue to improve care. I want to go. And lastly, just some resources if you want to know more. Texas Medical Association has a great page. HHSC has continued to update their pages for providers to help with keeping up with this ever-changing space. And with that, I will stop and turn it over to our next speaker. Thank you all so much, and I'm happy to be part of our panel.
Thank you, Dr. Schwarzwald. That was very informative, and we look forward to hearing more about this drop-off. I know I personally have lots of old computers that I'd love to donate, so thank you for making that plug. Our next speaker is Ms. Rhonda Mundhenk, and she is the Chief Executive Officer for Lone Star Circle of Care, which is one of the leading federally qualified health centers in Texas. Under her leadership, the Lone Star Circle of Care has become an award-winning health center recognized for quality and innovation. She has built a diversified workforce, mentoring over 146 physician leaders. She received her Juris Doctorate from Northwestern University School of Law and her Master's of Public Health from the University of Illinois School of Public Health. And with that, I will turn it over to Ms. Mundhenk.
Good afternoon, everybody. Thank you for spending time with me today. I have a confession as we get started. I have too many slides, so I'm going to blow through quite a few of them. I'm going to blow through quite a few of them so that we can get to the more interesting parts, I think, of the presentation. My hope today is to present a case study of a system. Lone Star Circle of Care was actually naive to telemedicine, but we've gone from zero to full implementation in a period of 60 days. And so that's the journey that I hope to share with you today. Quick look at our agenda. We have 6 points. I'll let you review those rather quickly, but these are the things that we'll go over in our journey this afternoon together. Lone Star Circle of Care itself is a federally qualified health center. And it has 23 locations in 6 counties, 55 individual clinics. And what's important for you to understand about federally qualified health centers, if you're not familiar with federally qualified health centers at this point, is that they provide care to underserved populations, including uninsured individuals, and they receive enhanced reimbursement for CMS payers, which is very important for this moment, specifically Medicare and Medicaid, to help offset losses associated with that uncompensated care. So that you have some sense of the overall size of the system and scale, 644 employees, 138 full-time providers. We organize our operations into service lines. We have full scope, OBGYN, pediatrics, family, senior optometry, and convenient care, which is our version of a retail clinic type environment. We have behavioral health, both psychotherapy and psychiatry, and we also have dentistry. A quick look at our visits by service line. You can see that pediatrics leads the way with 36%, followed by family medicine. We do have that large integrated behavioral health component at 18%, OBGYN at 13%, dental at 6%, and smaller proportions of the rest of the service lines. You can also see our patients by age group on the right-hand side of the slide. So you can see that there's about a good number of them that are children. All right, Almost half of our revenue is derived from CMS payers, and you can see that there in the Medicaid, CHIP, and other public, and the Medicare. You can also see that large component of uninsured patients that we carry. Over a third of our patients are uninsured, and about 20% with private insurance, which includes marketplace plans. From a race ethnicity standpoint, there's a lot of data on this slide. 3% Asian, 12% African American, 62% white, and 21% unreported. From an ethnicity standpoint, 42% Hispanic or Latino, and almost 80% of our patients are below 200% of the federal poverty level. You can see our total cost of care per patient is about $836. And for the third year in a row, we have performed in the top 10% of FQHCs nationwide. So anytime that we're looking at implementing something that is new or is different, we're always looking to implement that with a high level of quality and fidelity to the services that we already provide. This is a watershed moment, and it sort of collided with a long wished for solution. So if you're at all familiar with John Kingdon's sort of classic view of public policy, there are three streams that impact public policy. And when they come together, a policy window opens that creates an opportunity. And so we have a pandemic here, an economic crisis, and then, of course, recently civil unrest, all disproportionately impacting low-income communities of color. And one of the policy responses or solutions that has been available out there, which has been available, as mentioned previously, for many, many years, was telemedicine. And so obviously this was a moment where a policy solution sort of came into its own to address the circumstances in which we find ourselves. For Lone Star, the important thing has been that we have been able to CMS has relaxed its restrictions on telemedicine for beneficiaries. It permitted immediate implementation. And for many federally qualified health centers, including Lone Star, this emergency expansion marks the first time that we have been able to broadly disseminate telemedicine to all of our patients. There's pay parity-ish. Medicaid, for Medicaid payers, we have pay parity, but for Medicare, our average reimbursement is only 52% of the PPS rate at this time. So telemedicine, good, bad, and different, and for whom? There's a great promise in telemedicine, right? And so we have two sides of this slide. On the left-hand side of this slide, this is sort of the generic formula for value-based care that people advance. If you have the right care at the right time at the right place, then you have basically a formula for value-based care. And telemedicine, what vendors will tell you is it will reduce all of the other access issues that your population has previously had. And so at the end of the day, when you implement telemedicine for the first time, that right place now becomes two places. And so you have to decide what you're going to provide on a telemedicine platform and what you're going to provide from a face-to-face standpoint. The secondary thing that you have to think about is the only thing that really changes is accessibility. That for sure changes with telemedicine because you don't have to have people meet in the same place in order to receive services. But the rest of them really do need to be questioned despite what vendors will tell you. The biggest thing you have to question is whether or not you have the right patient. And we'll address that a little bit more on the next slide with the digital divide. So I'm not going to spend a lot of time on these slides because we have already spent some time on the digital divide, but really this is the economic, educational, and social inequalities that exist between those who have computers and can get online and those who don't. Obviously, for Lone Star's population, we really had to ask the question, if we use telemedicine amongst our patients, who will be left behind? And so we have three cuts here. The first cut is a cut that looks at race and ethnicity. And so you can see that there. The second cut is one by income. So you can see, in particular, I want you to focus on smartphones. Smartphones are really the primary device that our patients have access to, by which they can access video conferencing, which is the way that we're delivering telemedicine. So when you look at the rest of it, what I really want you to focus on here is just the smartphone utilization and then the under 30K group. Obviously, there are also disparities, if you will, by urban and rural, and you can see those there. if you just look at these and hold sort of these figures in your head, we're going to look at how those actually play out in the Lone Star population. And I'm going to suggest that there's a significant gap actually between these surveys and more research that needs to be done to see if people are actually able to access, in particular, video conferencing. All right, so I want to talk briefly about planning and implementation. And the biggest take home, or the biggest takeaway from this particular section is do not confuse the selection and the purchase of a platform with the work. Your telemedicine platform did not go to Hogwarts School of Magic. It's only a tool. You really have to put in the work in order to be able to integrate it into your system. Your first step, obviously, is to evaluate your IT architecture for successful incorporation of a telemedicine platform. The second step, obviously, is to select and purchase your telemedicine platform. Lone Star purchased Otto, which is a telemedicine platform that integrates with our EHR. You need to engage providers. So that was a big step. Palatability goes both towards what providers are prepared to do with their patients and then what patients are prepared to do with providers in this platform. And so we convened service line work groups that were charged with determinations about visit types that were appropriate or inappropriate for telehealth. And we also developed all of our organizational protocols and algorithm for management of known or suspected COVID-19 with our provider core. Step 4 was we revised our providers' procedures and schedules. All of this took place in 60 days. So you're also managing a change management process. This involves deciding what percentage of your capacity is going to be telemedicine, what percentage is going to be in-clinic appointments. We also deployed a split schedule for well versus acute. We built in cleaning time for an hour a shift. We revised our hours of operation. We moved to 24/7 coverage with telemedicine appointments from 5 p.m. to midnight. And thereafter, we converted call coverage to qualifying visits where appropriate. So we really were able to shift to a 24-hour coverage format that we were not able to previously with the deployment of telemedicine. Step 5 was the dissemination of scheduling protocols. We actually developed an app that we called Smart Schedule that led with telemedicine. So we developed an app with algorithms for determining the appropriateness of those visits according to the provider work groups and the COVID protocols. And then for all appropriate visits, that app first offered a telemedicine visit prior to a face-to-face. Obviously, we allowed patients to decline telemedicine if they preferred a face-to-face visit, but this way we knew we were throwing the doors open as wide as we could to this new technology and exposing as many patients as we could to this new technology that we had available to us. Provider and staff training, go live and ongoing IT support is obviously critical. The nice thing that we didn't think was going to happen was that providers actually now run an ongoing chat where they assist each other, new providers, other providers who have had issues. And if there is another level of service that's required, our IT provides that second line of backup. And finally, to support uptake among patients, we developed our own internal Geek Squad. And so this is a level down from the Pew Research Center's data. And I think it's very important to understand because you'll see it when we actually look at our preliminary numbers. Granted, they're less than 60 days, but we'll give you what we've got. You'll see that the data plans purchased by patients for their smartphones are very significant with respect to whether or not they support telemedicine and video conferencing. So what we did, because we had low clinic volume, was we redeployed staff to assist patients with actually testing their smartphones to ensure their technical parameters were sufficient to support a good telemedicine experience. And so this team began working on telemedicine appointments in arrears, but we progressed to offering real-time assistance as patients are making their first telemedicine appointments. So here are our selected results to date. Again, please bear in mind that these are very, very preliminary, less than 60 days. So we're really just sharing with you what we found in our hypotheses around perhaps why things may be the way that they are, but they are by no means tried or tested conclusions. You can see that the Geek Squad has processed through almost 15,000 telemedicine appointments. Of those, we were unable to reach 42% of our patients. So that's why we sort of propelled them to the beginning of that process so that as they were making appointments, they were also testing their technology. So that should improve over time. Of the patients we were able to get a hold of, only 50% were successful in testing their technology and 8% were unsuccessful. The payoff, mostly in the no-show rate. So you can see the no-show rate there by the successful test was only 10%. Our average no-show rate for face-to-face is 20%. So obviously that's a very dramatic improvement. But as we move to the next slide, what you'll see is you have to work for that payoff. The average no-show rate trend is about 14%, and you can see that it's all over the place on any given day. So you can see that there. So yes, is an improvement over face-to-face? Sure, but you really have to work for the efficiencies that you're looking for in your schedule. And our Geek Squad has been able to do that for us, best we can tell. All right, these are our selected results to date, our uptake by service line. This is significant, and in part, these numbers are likely driven by the provider work groups in determining the appropriateness or inappropriateness of telemedicine for services rendered. And you can see that OBGYN, so I want you to focus on the green. Green at this point is always the slices of the pie that I want you to look at. These are in order of uptake. So only 4% in OBGYN, 13% in pediatrics, increasing to 31% in family medicine, 47% in senior. And then we're going to take a little bit of a deeper dive into behavioral health, which obviously in the literature lends itself well to telemedicine. So you can see that 68% of behavioral health visits from inception until yesterday, I believe, were done on telemedicine. 32% were not. The other thing that I want you to look at, which is, again, very preliminary but interesting. So on the right-hand side of the screen, you can see depression screening instruments. And so we do this with all of our population, but these are behavioral health specific patients, obviously, although the non-BH is in the rest of the service lines that you see there. But I want to draw your attention to the second column in, which is the BH telemedicine. You'll see that the average PHQ-9 score was 8.4, and it went down to 7.7. Now, I talked to our behavioral health medical director, and she said that is clinically significant, that decrease, and she attributes that decrease to sort of a more frictionless approach to being able to get patients in when they need to get in, and so sort of being able to follow up faster in a telemedicine format than we otherwise would have been able to. So very preliminary, but an interesting look there. All right, here's the other potential cause for concern as we look at behavioral health that we've seen early on. So this is a subset of our population. This is actually a Travis County indigent payer that we, so a cohort that we work with, and this is a specific group of patients that we follow longitudinally over 12-month cycles. And what you can see, so the blue line is last year and the green line is this year. And our hypothesis was that, you know, we would have PHQ-9s going up, and what you actually see is them going down. And so the only thought that we had with respect to this, given all of the stressors that are out in the environment, is perhaps our sickest patients are either not coming in at all, either face-to-face or virtually, or they're not able, for whatever reason, to access telemedicine. So that may be a cause for concern. It's certainly pronounced. All right, here is our look at ethnicity. So you can see that non-Hispanics and Latinos use telemedicine more than our Hispanics and Latinos. And if you take a second look at that on the next set of charts, you can see, if you dig into that, go ahead. Okay, no, go back. Sorry, we're having a little bit of difficulty with the slides. You can see the Spanish speakers in particular were struggling to, or are struggling to access telemedicine with that 17% there, which is obviously likely a subset of the Hispanic Latino population that we provide care for. We have just received an integration for our translation services into our telemedicine platform. And so that should improve these numbers going forward, but it is interesting to see that, at least initially, in our data. All right, so private insurance, public insurance, and uninsured. If you look at the public insurance and uninsured, we can sort of proxy that for lower income people, and then private insurance, you can see on the far left-hand side, you can see that private insurance is obviously utilizing telemedicine more so than public insurance and uninsured. For all of the reasons that we've already mentioned, and perhaps because the publicly insured CMS payers and the uninsured are probably naive to virtual visits, it remains to be seen whether we'll be able to catch up those particular populations to what we see private insurance using. The other very interesting thing about all of these charts, though, obviously, if you think back to the Pew data, is that these should actually be flipped. They should all be flipped in terms of who has access to technology in theory that should be able to access that should be able to access video conferencing, and yet you see almost the exact opposite. So we're not entirely sure what to make of that, but perhaps it's a preference at the end of the day, regardless of your insurance status for face-to-face visits. Again, this is a split by urban and rural, and you can see that urban is using significantly more than rural. We know that many of our rural patients struggle with broadband access, so we're not overly surprised to see that there. All right, so as we look towards the future, we have hopes and we have concerns. Our first is obviously pay parity for Medicare. We would like to see that. We'd like to have continued pay parity for Medicaid. And for patients with access to a device that allows for video conferencing, telemedicine offers reduced opportunity costs for visits and, for example, participating in their healthcare. And that's a benefit for CMS beneficiaries, many of whom, work jobs without benefits. And it likely reduces accessibility, availability, and accommodation barriers. Also, and perhaps an early indicator of acceptability. Now, granted, we've completely flipped our system and there are a number of things that could be contributing to this, but patient satisfaction, and we do use Press Ganey and randomized sampling and all of that good stuff. And our overall score is 90.3%, and that's an all-time high for the organization since we've been tracking it over the course of 5 years. So perhaps an early indicator of acceptability. Our concerns, we obviously want to continue to allow telemedicine as an option, but not the only option, even if it is more efficient from a reimbursement standpoint. And the reasons are threefold. Not every patient can participate in telemedicine. Remember, between 20 to 30% of our patients can't participate at all. Not every visit is appropriate for telemedicine. And patients still evidence, even in the midst of a pandemic, a clear preference for face-to-face visits, best we can tell. So they're not availing themselves of this technology yet in the way that we would have expected them to, but it is still early. Thank you for spending time with me this afternoon. I appreciate it.
Thank you very much. That was an excellent presentation. Thank you to both of our speakers this afternoon. So now we'll transition to question and answer. So the first question that we had, I'll direct that to you, Dr. Schwarzwald. It says, how long does the equal pay for telemedicine last? Now I know that we have a crystal ball here, and I don't think our audience expects you to, but what's your speculation or what's your guess of how long this pay parity is going to last?
Sure. So at least right now, the regulation doesn't have an ending on it, right? Both the CMS regulation and the state regulation has not necessarily said it's going to end by June 30th or July 31st. So that's the good news. I guess the question really is it going to continue post-pandemic? And that I don't necessarily have a crystal ball to. I would think that it's going to depend. What I'm looking forward to is our ability to look at the data, look at the quality of care, look at the overall cost effectiveness, right? So if we can very effectively show we got more folks in for access, they came into the right access of care, they avoided emergency room visits, they avoided other types of visits, I think there would be a great argument for continuing that pay parity. I think there's going to be a lot of noise in that data though. Did they not go to the ER because they were worried about catching COVID in the ER? Did they not go to the ER because their needs were met in another way? But I think if we can sort some of that out, it'll give us a great opportunity to determine that.
Absolutely. And there's a second part of this question that was wondering about the pre-approval process or the approval process every month for pay parity. It says, does it have to be reapproved each month by CMS or the state of Texas?
Yeah, so I think what they're driving to that a lot of this pay parity came through two ways. One came through sort of the CMS waiver programs, and that each state had to apply to CMS for that waiver. So my understanding is those waivers are sort of in place until otherwise altered, right? So they're going to stay until it's declared that the pandemic is over, which none of us think is going to be anytime soon, and that will continue. At the state level, many of these changes have been sort of on a month-to-month level, at least for Medicaid. They've been sort of rolling out. First, they were going to end May 31st, then they're going to end June 30th, and we're all sort of waiting for HHSC to tell us they're going to extend them into July 31st, and our best guess is they're going to. The pay parity, though, that seems to not be month-to-month. It seems that it's there until sort of otherwise stated. So I think that's what the question is driving at.
Thank you. So our next question also ask you both to look into a crystal ball, but it'd be interesting to get both of your takes on this. And so we'll start with you, Ms. Mundhenk. So it says, what post-COVID HIPAA compliance software modality changes do you think will remain after in-person visits resume? And I think the crux of this question is, you know, with now us being more comfortable with Zoom and these other, you know, virtual platforms, do we think that the relaxation of these rigorous requirements are going to stay?
What I can tell you is, anecdotally, our patients are very comfortable with this modality. You see a lot of their lives, they take it with them. They're almost too comfortable at the end of the day in terms of where they're willing and ready to take calls. So I think from a consumer perspective, there's a relaxation. I don't think consumers even understand necessarily that you're purchasing an expensive platform that is HIPAA compliant and you're conducting their sessions in this way. To them, it's just FaceTime. And so I think the real question, so I think at a certain level, consumers are already giving you that. The question is on the other side, whether, you know, there's enough momentum, I guess, to get rid of some of the regulation that would allow providers to be able to communicate on more cost-effective platforms than, you know, purchasing something. Although what I can say is that an integrated platform saves you a lot of money on the back end, from a scheduling standpoint, from a billing standpoint, from all of those various and sundry things. So there are other things to think about besides just how do I reach out and talk to this patient.
Mm-hmm. Did you have anything to add, Dr. Schwarzwald?
Yeah, the only thing I agree with all those points. The only thing I can say is there's been some early indications from, you know, Health and Human Services that they're certainly considering leaving it open. So my best guess, and again, it's just a guess, is that we're going to end up somewhere in the middle, that they may rethink some of the HIPAA requirements, some of the compliance issues. My personal hope is they'll really look at relaxing some of the things that have been around text messaging that has actually made it very difficult to text with members and patients, and then balance that with how do we keep information safe. So my hope is we'll end up somewhere in the middle.
Mm-hmm. Yeah. Our next question relates to, we've been talking a lot about the provider or the patient side or the patient's experience with this, but our next question really has to do with how challenging has it been for the providers to implement a new system? And so I'll direct that to you, Ms. Mundhenk.
Yeah, it's you know, necessity is the mother of invention. I think at another time, we would have received, it would have been much more difficult to implement with the sort of alacrity that we were able to bring up telemedicine in our system. And the reason for that was there was a very clear reason that people wanted in particular to ensure that if we could manage COVID-19 patients or suspected COVID-19 patients at distance, we wanted to be able to do that. It was important to be able to do that for all of our patients, for all of our staff, for all of our providers. So I think the pandemic gave us a significant edge from an implementation standpoint. And what's been great to see in our provider core is that there are these ongoing informal chats where they are literally sort of putting their arms around each other and bringing each other along, because different parts of the system came up on telemedicine in a phased process over a period of a very short number of days, but you still had some providers out ahead of that curve who were able to turn around and help the providers behind them, and they turned around and helped the providers behind them, and so on. I also think that it really helped from a provider core standpoint in terms of their investment and their comfort level to literally let the service lines define for themselves what they thought was appropriate for telemedicine and what wasn't, and not to push the boundaries of that initially, to allow them to sort of figure that out, get comfortable in the modality. And now they're much more comfortable taking on things that they weren't initially. But I think that was the way to approach the process now that you have more than one place that you can provide care.
Yeah. And, you know, I have a question for you both. You know, investments in digital health have been the new thing. So, you know, Apple has transitioned into the health space. Google's now transitioning into the health space. So what is your perspective on providers, practitioners making large investments in telemedicine equipment, technologies for their practices in the future.
I can go ahead and start with that. I think that it's going to be a really unnecessary part of what everyone does. I hope as more people enter the space that cost will continue to go down, right? As it always does, as it gets better and cheaper in doing it. But I think that as providers and as we look towards the future, really thinking about how much do we continue to build buildings, right? How much do we continue to truly build buildings and spaces, and how much do we start to invest in the technology? And I think that this is a great opportunity to let some of those possible disruptions play out.
Yeah, I think that's very true. As a bricks and mortar, organization, this is something clearly that we have to think about for a future. What I will say though is if you go back to that service line cut that I did on the data, what's very clear is that there are some things, even from a patient standpoint, that there's not a substitute for in telemedicine. So it's sort of there's the acceptance of the modality as somewhere where I'm going to do this kind of interaction. And then there's what is possible. And so that may evolve over time with consumers as they grow more comfortable, perhaps with the digital environment. But I think from what you see from that service line look, and granted, some of that was driven by our providers, but you see a very clear evidence of people bringing themselves in the midst of a pandemic. And that was just not something that I expected to see actually until we pulled the data. I really expected for people to be jumping onto telemedicine as fast as they could. And you could see those very clear and distinct, even early on, looks in the data.
Our next question says, as reimbursement models uphold outcomes over volume of services rendered, how much telehealth will advance the transition to value-based care agreements for primary care services?
So I'm happy to jump in on that. So I think that this is a great opportunity to advance exactly that. I mean, many of our primary care providers have seen a massive drop in their volume. And so I am hopeful and excited that this is going to be a real opportunity to start to look at really accelerating value-based care. I will say though, some of the barriers that have always existed to value-based care do continue to exist. So it remains ensuring you have appropriate attribution, ensuring that you've set up the right kinds of quality metrics, ensuring that you have the right systems in place to do rapid exchange of data. But again, as we talk about Google and Apple and others coming into the space and accelerating that, the more we do to share that data, the better. And that may be another sort of silver lining to some relaxation of some of the HIPAA rules. Will that make it easier for payers and providers to share some of that data back and forth and allow even better value-based contracts? So I think it's going to definitely accelerate that space. But I think we still have a few things we have to overcome that didn't go away.
Yeah, I think that's very true. One of the things I'm concerned about, obviously, as we look at who's left out, is I wonder if those aren't our high utilizers. As we look at that sort of behavioral health side, and we see people getting better as opposed to getting worse in a telemedicine format, is that because our sickest patients can't seem to convert to that modality or whatever the case might be? So I think there is a ton of opportunity. It is obviously a more cost-effective way of delivering a lot of care, and so that's something that needs to be thought through carefully. But I also think that when you pair that with your highest utilizers may be the people who are left out of this equation.
Mm-hmm. Yeah. I think a related question to that is around privacy. So next question is, are there certain instructions or provisions made for patients, particularly for like the behavioral health visits, where you instruct them to make sure that there's no one else in the room, or that the things that they share might be overheard by other people? How are we maintaining patient privacy?
Yeah, it's a good question. What I can tell you is some patients are very concerned about it and some patients are not. So we've learned a lot as cameras come on in people's homes at the end of the day in terms of their comfort level with whatever's going on. But we have also had the experience of, people going to the car, for example, so because that's the place where they can be alone and have the conversation. And I think the most interesting place where somebody has done a telemedicine visit is from a high-rise crane, on somebody's lunch hour building a skyscraper in downtown Austin. So people are finding ways to be alone, if you will, and they're pretty creative.
Yeah. So we have 5 minutes left. So I just want to take this opportunity to thank you both for your expertise in sharing this information with us today. I know that I found it very interesting seeing how telemedicine is rolling out in the midst of a pandemic. There were some questions about your slides, and so I want to let the audience know that if the speakers decide to share their slides, they will be posted on the Baker Institute website along with a replay of this webinar. And then Dr. Schwarzwald, there's been some interest in this nonprofit for the computers.
Absolutely. And maybe the best thing for me to do is type their name in the chat and then people can see it. So again, I just have to, full disclaimer, it's not something that Aetna supports, but they're just a group that I know about personally. But I'm really happy to kind of type their name in there. See if I can do that. Yeah. So I will go ahead and do that.
Yeah, and we also perhaps can also post this on the Baker Institute website along with your slides if you so choose to share them.
Sure.
So that people can. Because I know as many probably of our participants as well can relate to access to computers, particularly if you have children, is critical in this period of time. So thank you for sharing that information. And thank you all for attending our webinar today. I hope that you found it helpful. Feel free to reach out to me directly. You can find my contact information on the Baker Institute website. If you have any follow-up questions or want to learn more about how you can get involved in the Baker Institute or support any of the other organizations that we talked about today. So thank you all. And I think Heidi, you're gonna post it, or have you already posted it?
I think I did. I was trying to. Did I get it right? No.
No, it didn't show up, but we will. We'll also have a link. Is that an organization that has a website?
It does. So I'm happy to give that to you to put up at the end.
So she'll email it to me, and then we'll also post it on the webinar. So thank you again to both of our speakers. It was a wonderful presentation, and we appreciate you taking the time to spend with us today. Thank you.
Thank
Bye-bye.
you.